I'd like to welcome to the podium Dr. Andrea Natale, a world-famous ablationist. He doesn't need an introduction. But thank you so much, Andrea. Please.
Thank you, Steve. It's a pleasure being here. So I apologize because unfortunately we have another program start at 7. So I'm going to give my presentation and then I'm going to unfortunately have to leave. But it's a real pleasure being here. We've been involved with Vivek early on with the technology. So I'm excited. I don't know how Vivek feels, but I think if Vivek feels the same way. So I'm gonna okay. So I'm gonna show you one of the cases we did. And before I will go very quickly through our approach. So our group started with what we call homogenization, which is substrate-based ablation, which most of the centers do now. Okay, thank you. Really the benefit. So in the first series, which was not randomized, we kind of select patient where we could do endoepicardial, and by doing endoepicardial homogenization, we were able to achieve better results than what was the standard approach at that time, which was a sort of a middle between substrate and induction and mapping. The biggest benefit from this result is that not only freedom from recurrence is higher, but also the ability to stop antiarrhythmic drugs in more of the patients, the homogenization was way higher than the other group. So that's the best benefit. This was followed by a randomized study. It's called VISTA, where we included patients that presented with stable VT, and they were randomized again to a sort of substrate-based approach versus the standard mapping and ablation. Again, better result with the homogenization approach. And again, even in this series, look at the difference between people that were able to stop antiarrhythmic in the two groups. So huge difference. And antiarrhythmic for this patient is most of the time amiodarone, so it makes a big difference. More recently, we published a 5-year follow-up with comparing endoepi in ischemic cardiomyopathy versus endo only, and you see the difference of 5 years. Again, by doing the endoepi homogenization, the results are better than just the endocardial approach. So there is a benefit, even if in ischemic we think that is not that big of a deal, but actually there was a benefit, a significant benefit at 5 years. We did the same with non-ischemic, and this is one of the cases I'm going to show you. In non-ischemic, the results are still better than the standard approach. Even in terms of acute complication, actually, there was a lower rate of complication in the substrate-based approach than in the mapping and ablation, especially in terms of kidney function and prolonged hospitalization. But in the non-ischemic, we have issues that are due to what? Which are the patients that continue to have recurrence? So mid-septal scar, mid-myocardial scar, especially in the periannular, in the perimitral region, and more rarely other type of arrhythmia like bundle branch reentry. But the two most common reasons of failure with that approach is really mid-septal or mid-myocardial scar. Those are really, and this is not a dismal group. It can happen in a significant number of patients with non-ischemic cardiomyopathy. So I'm going to go quickly to the case. This is a 63-year-old male. They also had an ablation for atrial fibrillation, a dilated cardiomyopathy with an ejection fraction of 25%, a CRTD. It came to us after 2 previous ablation that failed in a good center. We did a third one, and I'll show you what happened after. The last one that actually we did, still with RF, was in 2024. The issue with this patient is that hemophilia, so it means that every time we do a procedure, we need to infuse factor VIII. So is a patient where when we did his ablation, we did not want to go epicardial because of the underlying hemophilia. This is ECG. So look at this is the map of the third ablation that we did after the two previous failed in another center. So here you see mostly a septal scar. The two ablated both from the right and the left. And I have to say that all these cases are done with my partner in crime, is Dr. Burkhardt. I want to give him credit because he's the master of VT in our center. So we did this with RF. And he did okay so the ablation was in September. He did okay for 2 months off antiarrhythmic drugs. And then he had some pacing therapy in January. But then he went on a trip to Singapore. He's actually from that area. He came back to US, and in 2 weeks, he had some more ATP therapy. In 2 weeks, if you can see that he got in 48 hours 6 shock and 16 ATP therapy, and he was like in and out of VT. Okay, so this is an example of one of these episodes. There was pace and then shock, but that was the scenario. Is now on amiodarone. This is so we map it with Smart Touch first. The earliest activation that we got endocardial is what you see here. So clearly, this is not an endocardial substrate, is what we saw before, sort of a mid-myocardial. And this is the map with the pulse field medical, similar activation. So, but this is the earliest we had. This is the map. The map show a little bit of a lateral extension as compared. If you remember, the other one was just septal. This is kind of extending a little bit to the anterior area. And those are, you can see some of the lesion. So I'll show you now. Let me go to, can you run the movie, please? So this is what he was doing. He was having this constantly, this short run, on and off, on and off. You see this short run. So we were able to map it, and I'll show you the map. This is the first delivery. With the first delivery at the earliest site, and I'll show you the next one. Those non-sustained episodes that were ongoing constantly stop. Obviously, we continue to ablate. This is the lesion number 2. And you see that now you don't see those non-sustained episodes. They're just really with the first application, they disappear. But obviously, we continue to homogenize the scar. And this is the final lesion set. And the patient, since the procedure, has been now 3 months off amiodarone. No event. Actually, was interrogated because I wanted to make sure. It was interrogated a few days ago, and no event off antiarrhythmic drugs. And actually, when he came to us, he was on Sotalo and amiodarone, despite that combination was having this sort of ongoing episode of VT. So now, off all antiarrhythmic drugs, 3 months, no event. So good outcome, I think. Thank you.